Hello, welcome to our webinar on retinal vein occlusion. Let me share with you our experience in retinal vein occlusion, how we are currently managing retinal vein occlusion, and a new clinical trial for which we are recruiting patients. This webinar it provides one CPD point from the Royal College of Optometrists. These are my commercial disclosures. Why the Retinal Clinic London? Let me talk a little bit about ourselves. We offer bespoke patient-led care with over 30 years of expertise, and we are a clinical trial center. So we are certainly looking forward to your referrals and working with you. We have two sites, a main site, 24 Queen Street, our retina clinic, and we have a research facility at 140 Harley Street, where we do part of our clinical trials activity. I don't work alone, of course. I'm supported by a large and superb team, as you can see. And I'm supported also by a team of consultants, Professor Ailiff, who specializes in cornea and inflammatory diseases, Professor Downs, who specializes in inherited retinal diseases, Professor Rupert Bourne, glaucoma, Professor Dominic Fisher, Mr. Tong Park, Mr. Kanmin Su. They are vitreoretinal surgeons like myself. We have always an anesthetist with us in our surgical procedures and the laser procedures that requires intravenous sedation, Dr. Septarik, and Professor John Marshall, who is our Associate Director of Research. When we are managing retinal diseases, we depend significantly on ultra-wide field imaging, as we've discussed in many of our previous seminars and meetings. I would like to draw your attention to this publication of us. A couple of years ago, a group of us got together in a consensus group led by Nathan Chowdhury from Canada, and we published a new classification and guidelines for wide field imaging. So what is wide field imaging? What is ultra-wide field imaging? So we have to remember that the posterior pole is an area encompassed by an ellipse that limits the area to the retina within the arcades and a disc diameter nasal to the optic nerve head. Between the posterior pole and the posterior edge of the vortex veins, that's the mid-periphery, and anything anterior to the posterior edge of the vortex veins, that's the peripheral retina. And this is a single scan image and not a montage. So to be able to claim that we are doing ultra-wide field image, with a single image, we have to reach beyond the posterior edge of the vortex veins. This is how we do ultra-wide field imaging. This is ultra-wide field fluorescein angiography. And now we are also doing ultra-wide field OCT imaging. This is our preferred device at present, 1,050 nanometers wavelength. We're using infrared light, 200 kilohertz speed, so high speed imaging, 130 degrees field of view with a single scan, and that's 26 millimeter long imaging scan. Most scanners nowadays achieve 12 millimeter imaging. We started with 6 millimeters. We moved to 12 millimeters approximately 6 years ago, and now we are at 26 millimeter long single scans. But this device has an imaging window of 12 millimeters, so we image deep into the vitreous cavity. We are big fans of ultra-wide field single scan OCT angiography, and nowadays we are relying on the same device, which single scan 150, OCT angiography, and with we reach 220 degrees, so almost the entirety of the retina. So let's move on to the topic of today, retinal vein occlusion. This information comes from the Royal College of Ophthalmology's guidelines on retinal vein occlusion, and the publications from Hayre and Song, a systemic review meta-analysis from 2015 with people aged 30 to 89 years, and the prevalence of any type of retinal vein occlusion was 0.77%. In terms of incidence, the reviewed pooled data found that the 5-year cumulative incidence was 0.86%, and the 10-year cumulative incidence was 1.63%. The cumulative probability of a second retinal vein occlusion, the same or different type in the same eye, was 0.9% within 2 years and 2.5% within 4 years. And this is important to remember when we have an initial discussion with the patient, because it is always possible for a patient to suffer another vein occlusion in the same eye, or of course in the contralateral eye. This is why it is so important to control as much as possible systemic risk factors. So let me share some of our patients. As you can see here, upper left, this was the first assessment back in 2019. You can see some peripheral hemorrhages, and 6 years later, the same eye, same patient, you can see that there are increased hemorrhages. This is after 28 intravitreal injections for controlling the macular edema and peripheral laser photocoagulation to the area of non-perfusion, so 6 years down the line. Here you can see the angiographic results, and we can see that how there's been further reduction in the retinal perfusion from 20 CT scan, ruling out edema after successfully treating the patient with anti-VEGF, and you can see the area of persistent or ischemia, retinal non-perfusion, and how we treated this area with sectorial scatter, ultra-wide field transfusing, angiogram-guided laser photocoagulation. Light intensity laser, we are not looking to destroy the retina, we are not looking to carbonize the retina. Let me share with you further examples. You can see how this patient suffered a further vein occlusion in this patient. This is a patient in this eye. This is a patient that suffers from atrial fibrillation. As you know, this can lead to peaks in blood pressure, and the patient suffered a further vein occlusion in the same eye. And we carried out further laser photocoagulation, as you can see, very light intensity without carbonization. Here you can see the recurrence of macular edema, and this is a very common problem, a very common concern that we have to keep treating patients because of the recurrence of macular edema. The standard treatment at present, is for the patient. The perception of the patient is that it is never ending. Here, let me show you the presentation of a patient with a supratemporal branch vein occlusion with macular edema, and you see the application of laser to the area of peripheral non-perfusion. And you can see that the patient has already had 12 intravitreal injections plus laser, and we keep, of course, treating this patient up to this day. So we need to desperately find a treatment not just to ideally unblock the occlusion, but of course to reduce the dependence on anti-VEGF intravitreal injections. Let me show you the correlation between fluorescein angiography and ultra-widefield OCT in the same eye. You can see here the patient I've just shown. You can see the area of superior-temporal retinal non-perfusion on fundus fluorescein angiography, the early and the late phase. And you can see in the center of the slide the corresponding ultra-widefield single scan OCT angiography. You can see an excellent correlation, and both technologies are ideally necessary. Ultra-widefield OCT angiography will more clearly define the area of non-perfusion, while ultra-widefield fundus fluorescein angiography will show us vascular activity, will show us leakage, will show staining of the vessel wall. So it is important in an ideal world to carry out both examination techniques. The presentation got stuck. Give me a couple of minutes because for some reason the presentation is not advancing. Let me ask for some technical help. Perfect. Now we are back on track. Thank you, Sebastian. So this is a patient with a superior-temporal, it says infratemporal, but it's a superior-temporal vein occlusion. You can see the sectorial laser photocoagulation. You can see the intensity of the laser, and you can see the cross-sectional OCT at the time when the patient was free of edema. Where I prefer to do the laser treatment at the time when the patient is free of edema. So normally I inject the patient, and 3 weeks later I carry out the laser photocoagulation. And you can see here how we can very objectively follow up ischemia with OCT angiography. You can see the same patient image in 2023 and image in 2025. Another example, superior-temporal branch retinal vein occlusion. You can see the area of ischemia. You can see the silver blood vessels here and the sheathing. You can see the significant retinal hemorrhage there. And this is the corresponding fundus fluorescein angiogram and the area of retinal ischemia in the periphery, very clearly demarcated. And in the later frames, you can see the staining of the blood vessel wall. Here you can see the area that I've treated, how I've treated this patient with sectorial laser to try to reduce VEGF production by applying light laser photocoagulation to the area of mid-peripheral retina. This is another example, a patient with significant cystoid macular edema, multiple hemorrhages in a patient with a hemiretinal vein occlusion. However, there is relatively well-perfused retina. We don't see clearly defined areas of non-perfusion. 1 month post-IVT, intravitreal therapy, you can see already reduced retinal hemorrhages. Here another example, a patient with a second central retinal vein occlusion 3 months after the first vein occlusion. It is very important to remember to discuss this with patients. So we are recruiting patients at our clinic for a clinical trial with a new treatment, which I'm going to discuss now. We are recruiting patients with proliferative and non-proliferative diabetic retinopathy and vein occlusion. So this is an open label safety, tolerability, and proof of concept study to validate the use of human recombinant annexin A5 for the treatment of patients with either non-proliferative diabetic retinopathy or recent onset retinal vein occlusion. So this is retinal vein occlusion that's within 28 days from diagnosis. We exclude patients that have received previous intravitreal therapy, of course. And in terms of, we are also recruiting patients with diabetic retinopathy with a score of from 35 to 61/65. That's mild or moderate proliferative diabetic retinopathy that does not require immediate treatment. So let's talk a little bit about annexin A5. This is a clinical trial that has already got IRAS approval. So this is a fully approved study. And these are several publications from different parts of the world reporting on the benefits of annexin A5. So this is a novel mechanism of action. Annexin 5 acts upstream of VEGF, angiotensin II, TCase, and complement pathways. So we have to remember that annexin acts as a homing molecule to sites of membrane damage, and it targets binding to sulfatidylserine and creating a shield over stress cells, as you can see here in these images. You can see the healthy cell membrane, and you can see that phosphatidylserine PS is strictly inside the membrane. However, in a stress cell, you can see the patches outside, on the outside of the membrane. And on the right-hand side, you can see how annexin A5 creates a shield over the stressed cell membrane. So this shield protects cells from further damage. It stops the initiation of multiple upstream signaling cascade. It reduces adhesion, inflammation, and ischemia, and the aim is to start their cellular repair process. So in terms of the mechanism of action, we have to remember that annexin is a human recombinant protein, annexin A5. As I've just described, it acts upstream, and we hope that this will have an impact, a long-term impact, modifying the disease by decreasing the occlusion itself as soon as possible. That's why in terms of vein occlusion, we're looking for patients that have a diagnosis younger than 28 days. We want to improve retinal capillary perfusion. We want to stabilize cell membranes and reduce inflammation, edema, and angiogenesis. And this is what I've just explained in a summary. We really think that annexin 5 has the potential to modify disease by stopping chronic progression and targeting directly the occlusion and the vascular wall. We all know, we have to remember that ischemia in the deep vascular complexes triggers VEGF production and angiotensin II. And the deep vein complex and outer retina are significantly affected in retinal vein occlusion. And this leads to VEGF production, secretion, which in turn leads to increased retinal fluid and atrophic changes in the outer retina. And so far, the standard of care in retinal vein occlusion are anti-VEGF injections. And as we know, unfortunately, it's not one, it's not two, it's not three. Unlike patients with age-related macular degeneration of the neovascular type or wet type, these tests, which sometimes have a break of some months where the disease is inactive, in vein occlusion, this tends to be a constant usually in most patients, every 5 to 6 weeks. Now, annexin 5 is an intravenously delivered treatment. So a phase 2A proof of concept study has already been conducted. An open label dose escalation proof of concept study with recent onset retinal vein occlusion. 16 patients were enrolled with vein occlusion of less than 28 days from diagnosis. In more than 50% of subjects, there was evidence of ischemia at baseline. And this is important information. From a safety profile, the treatment was generally safe, well tolerated, with no drug-related ocular or systemic adverse events and no anti-drug antibodies detected. At 4 months, 62% of eyes remained anti-VEGF free, and 38%, only 38% required a single injection of anti-VEGF. And these are significant findings. Very importantly, there was long-term durable vision gains with no rebound of macular edema with up to 30 months of follow-up. And these are significant findings. In terms of clinical improvement, the visual gains were durable. The fluid decrease was significant. There was rapid increased deep macular capillary non-perfusion in up to 60% of patients, and there was complete resolution of hemorrhages in 45% of eyes at 4 months. So these are significant findings. In summary, annexin 5 was safe and well tolerated. There was reduced anti-VEGF use after annexin 5 treatment. At 4 months, 62% of eyes remained anti-VEGF free, and only 38% of eyes required a single anti-VEGF injection. Remember that most patients undergoing standard care receive anti-VEGF injections every 5 to 6 weeks. Annexin 5 allowed for rapid and durable effect of treatment with long-term effects and durable vision gains with no rebound macular edema with up to 30 months of follow-up, including in cases of ischemic retinal vein occlusion. In terms of functional and anatomic improvement, there was increased deep macular capillary perfusion, as shown by OCT angiography with segmentation in 60% of patients. There were resolution of retinal hemorrhages in 45.5% of eyes at 4 months. So this is a single treatment cycle, monotherapy, no other treatment. These are 5 daily injections with significant improvement and response, as I have just shown you. Here you can see the curves looking at macular capillary perfusion and visual gains and fluid control. As I've just mentioned, and I repeat this because this is significant, at 4 months post-treatment, 62% of eyes remain anti-VEGF free, therefore no injection for 4 months in 62% of eyes. Only 38% of eyes received a single injection of anti-VEGF. There was a significant improvement in vision, and the visual acuity gains were most profound in those eyes with visual acuity below 70 letters or ischemia on ultrawide field fluorescein angiography. Again, significant reduction in central subfield thickness on OCT imaging. Here you can see the percentage of patients that had resolution of hemorrhages, which was 45% of eyes had complete resolution of hemorrhages. And in all patients, there was a degree of retinal hemorrhage resolution. We can see here also improvements in microperimetry. Thank you very much for joining us today. We are certainly looking forward to your referrals, and we look forward to your questions. I'm starting to receive some questions now. So which patients are we recruiting? And let me open up the slides again. So here you can see inclusion criteria, patients within 20. The most important criteria is a fresh vein occlusion, naive of treatment, no previous treatment, less than 28 days from diagnosis. We are also recruiting, remember, diabetic patients as well. In terms of referral, it's very easy to refer patients to us. All we need is an email. I think I'm receiving more questions. Yes, supplemental injections. Sebastian is telling me, can the patient receive rescue therapy? Yes, the patients can receive rescue therapy after 2 weeks following treatment with annexin. We do the trial here at the Retinal Clinic. The infusions are done here at the clinic as well. Looking at more questions. Are travel expenses covered? And is the study free of charge? Yes, the study, of course, is free of charge. It's got IRS approval. Travel expenses are covered, and the patients receive a compensation fee for the time they spend as part of the trial. Is there any potential harm from doing this? If it doesn't work, there can always be a reaction to the drug, of course, but there is rescue therapy, so we can always carry out the standard care, which is intravitreal injections. Another question, why is this better than standard of care? Well, because if successful, this will be a paradigm shift in the management of retinal vein occlusion. Because at the moment, all we are doing with retinal vein occlusion is treating the aftermath of the vein occlusion. We are treating the edema. We are doing repeated injections to try to reduce the edema, and we are not preventing a secondary episode of vein occlusion. We are not targeting the vascular wall. We are not preventing further damage down the line from the moment the vein occlusion takes place. With this new therapy, we're aiming, as I said before, we are targeting the actual occlusion, we are targeting the vascular wall, and we are trying to reduce the dependency on anti-VEGF injections, and also, hopefully, trying to reduce the risk of a secondary vein occlusion and the worsening of ischemia further down the line, which is something that we see in a number of patients. For diabetics, what about early proliferative disease? Can we refer those? Yes, you can refer patients with early proliferative disease, patients that do not require urgent retinal photocoagulation, and with neovascularization as well, less than 1 disc diameter. More questions are coming in. Why will this benefit diabetics as well? Because as we are targeting ischemia, areas of non-perfusion, and targeting the vascular wall, we believe that there could be a benefit for patients with vein occlusion. And we have to remember that this is a systemic treatment. We are delivering this treatment intravenously, the vein of the arm. We are already treating patients. We've already enrolled the first patient into our trial. The patient is already undergoing infusions. They are very well tolerated so far, and we believe that this treatment could provide benefits for vascular occlusions in other organs beyond the eye. So we are very hopeful about this treatment. Let me see if there are more questions coming in. I think we can close here. There are no more questions coming in, and we have to end the webinar on a high note. And thank you very much for listening to me, and we look forward to your referrals. Please do not hesitate to contact us at any time you have any questions, and we look forward to seeing you again. Thank you, and many thanks.